that you've done to get that aligned and functioning
well. Yeah, it was a little bit of a struggle to get that aligned, and that was we did it with Gen 2, but I think he was okay. Okay, thank you. We didn't have a hinge ready because the Gen 2 had that constraint plus. They have the constraint plus, so we had that ready. That is the only thing available at that time. Yes. X-ray? No, patella is fragmented now.
When you did the primary index surgery, patella was brought back to the original level?
Yes. There. This is the post-op X-ray.
Okay. Because if it is a patella baha, the chances is very high.
Yeah, but this happening at 12 years, I don't know why. That's what I thought I should. He's doing well at 12 years. The patella is fragmented, but thank you.
Next talk would be a case presentation on a complex primary TK by Dr. Derek Pick.
Thanks. Yeah, great. Thank you. Thank you once again. I have to confess, these two cases I got for case presentations are not my own because I thought they were far more interesting than the cases that I had myself. And it goes on a theme here. So it's a 71-year-old male, rheumatoid arthritis, on various drugs, a range of movements, not that great, and the valgus deformity was partially correctable. Not the worst deformity in the world that you've seen. And so what sort of implant and what sort of approach would people do here? Sorry? Rheumatoid arthritis, yeah. Anyone for a lateral approach? Just one hand, sole figure. Medial parapatella? Probably the majority if I'm going by last night. And what sort of implant? It's just a straightforward cruciate retaining, cruciate sacrificing. Yes. Yes, well my colleague decided that it almost certainly would. And so templated it for this global modular revision system. Replacement system made by Stryker. And in February 2018, did very well. Good result. Yeah, well, I don't think so. So he went the full rotating platform on a hinge using a medial parapatella approach. And the reason I sort of bring this up is because that was the X-ray 8 weeks later, and you may notice the absence of the patella. When before, can I go back? Yeah. It was looking absolutely perfect. He reefed the medial side because there was an awful lot of pannus. There was a lot of synovium and a bucket full of debris came out of this knee, which I think surprised him at the time. But he was very happy until he saw this X-ray. And then, of course, you've got to get an AP view, so the patella hasn't disappeared. It's still there. But smiling at us. And then 1 year, it's flipped around another 90 degrees. Patient has got a lot of comorbidities, doesn't want anything done about it. At this stage is able to straight leg raise to a fashion using probably his iliotibial band. So that was and then 4 years post-op. He's still functioning, but the worry is that that's what's happened. So he's, despite having a very long sleeve, yeah. My colleague was very keen to get his hands back in there to try and correct this issue. And in hindsight, thinks he should have used a fixed hinge. In hindsight, I mean, hindsight's a great thing, but I really think he perhaps should have used a lateral parapatellar approach. I've done it, I would say 4 times, and I haven't done it for 20 years, but the times I've done it, I've not tried to close. It's just the big lateral release for this type of problem. And here's a study from Japan that kind of says that the randomized 24 patients in each group, and they seem to do a little bit better with a lateral parapatellar approach. However, so that's trying to show lateral parapatellar approach. But there's some good evidence from India that actually it doesn't make any difference. So I don't know the answer to that. As I say, in hindsight, I would probably have done a lateral. I mean, if I'd had the case, but from the case you've just presented, a medial parapatellar is absolutely fine if it's done properly. And no disrespect, he's a respected surgeon, but he just didn't quite get it right there. I think that's the last slide. Oh no, I'm not going to show that. Right.
We'll have a Q&A session on primary and complex primary. Any questions from the floor? If not, I'll have a question. I'll open up with a question to both the faculties. There's a lot of debate and controversy regarding the BMI and use of stems, especially on the tibial side. And a lot of papers, especially a recent paper in 2025 from the American Joint Registry, has said that there's absolutely no relation between the body mass and tibial component loosening. So what are your thoughts, and what is your current practice in the use of tibial stems in primary knee replacement and BMI?
BMI more than 35, more than 30, 35, but more than the BMI if it's a significant varus or valgus, and you've done a significant correction, then probably drop a stem, but not just necessarily BMI.
Yeah, oh, sorry, yeah, my mic's on. In our hospital, the general practitioners are not allowed, allegedly, to refer anyone with a BMI of over 40 for a knee replacement. Hip replacements, it's just what pragmatically can be done. But as I say, I showed those, the injectables, I'm going to call them, not the Incredibles, with injectables, which seem to have revolutionized, to a certain extent, thoughts in the UK at about £200 a month. Patients that you wouldn't actually think should be using such things because they're meant for diabetes and not relatively side patients. But I think in the morbidly obese, I think they may provide a significant improvement. And anecdotally, I think some of these morbidly obese patients, once you get their weight off, they don't actually need a knee replacement because the symptoms aren't that bad.
Right. There's a question from the floor to Dr. Anil on one of his cases. He's asking why no stem in the femur, why only in the tibia? One of the cases that you presented is why no stem in the femur, why only on tibia?
Why didn't I use a stem in the tibia?
Yeah. Why not femur, only tibia?
No. Basically, when I attempted, for the one that perforated, we attempted a stem on the femur first. Okay. Then I thought it was, basically we used a PS type of insert, so I didn't want a stem in the tibia, only unless I was going up in the level of constraint. Right. And for the second one, the Gen 2 had a longish keel. That didn't require a stem because we didn't use, unless we added a constraint, I wouldn't have used a stem.
Right. Regarding the implant choices that Dr. Derek talked about, so what kind of implant do you use? I mean, is it do you use a CR knee or a PS knee or a CR with deep dish? I'm asking that because I was a full-time PS, posterior stabilized surgeon, But once I started with robotics,
Yeah.
I started using the CR with the deep dish, and I was quite comfortable with the outcomes.
Yes, and I think, I mean, as I say, looking at that big data, it does seem to be better. And I don't know, my feeling is you've got to get the balancing right. And I think that's what's exciting about the robotics. I've never done a robotic surgery, so I'm admiring the people that can switch the robot on, because I don't know where the button is. And a time is going to tell. But I think my concern is with the posterior stabilized is that if you haven't got the balance right, you're relying on that a little bit of polyethylene. And I inherited a practice where someone was putting rotating platforms, hinged rotating platforms in 55-year-old farmers who were just trashing the knee within 5 years. So I kind of, my practice has been colored by that. But I do support your feeling, and I've heard that from other surgeons that using robotics, that they feel more comfortable with it. And if that's the one thing that robotics does, I think it's a winner, personally.
Yeah. Ranil, feel the same?
Yeah, but I've been essentially a CR surgeon, so I think CR with the dish, and I'm right now using the Persona, which has a medial congruent,
Right.
and the ultra so, and it's a very, very good knee. In sense, so CR with a CS design is a very good option rather than a PS.
Yeah.
Right.
Mr. Derek, could I ask a question? Thanks for the great presentation. So you mentioned that you are a kinematically aligned person. So what do you use navigation for that? What do you do? That's question number one. Number two, with the big data, what you just mentioned, what is it telling us regarding alignment, regarding CR versus PS, regarding patellar versus no patellar resurfacing? What is it teaching us, the big data?
Yeah, so yes, I try and go for kinematic alignment. Sorry, it was just the echoing. I couldn't quite...
Yeah, with the kinematic, what are you navigating? Are you using a robot? What are you doing?
Yeah.
How do you get kinematic alignment?
Sorry, how...
With technology, using the robot for kinematic alignment?
Yeah, well, I would, but I think... Yeah, I mean, you've got the time, the opportunity to plan and get some handle on the tension as well, because I believe you can sort of dial in what sort of tensions you are expecting. But at the end of the day, I think you've also got to have a feel and have experience of others doing it while you're a trainee and done it under supervision, because I do feel, how much medial release you do for a varus is important. And nowadays I'm preserving the infrapatellar fat pad, because I think it's very important to minimize the risk of infection. But it's getting all these things right.
Yeah. What about the big data? What is it pushing us towards? Is it pushing us towards a particular alignment, or, for example, CR versus PS? Patellar resurfacing versus not resurfacing. What is the big data telling us as far as knee arthroplasty is concerned?
My opinion is it's pushing us towards kinematic alignment. And as I say, I think we could talk all week about the patella. There are small advantages in resurfacing the patella. And one of the issues locally within the region is if you don't resurface the patella, you're under risk that your patient will pitch up to another surgeon and says, oh, you've not had your patella resurfaced, you've got a painful knee. It's not due to the fact the patella's not being resurfaced, it's for other reasons, but they're getting a revision operation.
Just to add to that, there's been a latest set of publications saying that there's no difference between kinematic and mechanically. In effect, robot versus non-robot. Large meta-analyses have come out, long-term data or whatever data they have till now, no significant advantage.
That's from Australia, is it?
No, these are meta-analyses, both from US and from Australia.
Thank you.
Yeah. Okay. We ended. Thanks for
Thank you.
joining
Thank
us.
you.
I think we'll start the revision session we have 3 talks today on revision. I'll be starting with my cases first. I have a couple of cases to show. The first case is a 57-year-old female with left knee pain since a couple of years, but increased for the past 4 months. The index total knee arthroplasty was done 7 years back, and she has no comorbidities. So what would be your diagnosis? Is a Yeah, I think the first first thing for revision is to establish a diagnosis. Without knowing the diagnosis, you should never go in. And the three most common reasons for revision is, one is infection, second is aseptic loosening, and third is instability. So this is a case of, the infective markers are normal, so it was a case of aseptic loosening. You can see that there's a gross change in the position of the implants gone into varus, and you expect that this region would have a lot of metallosis because of eccentric polywear. And so that was how she was walking with the varus thrust gait. Went with a straightforward medial parapatellar approach. You can see the extensive poly wear there on the posteromedial aspect, and a bit of metallosis there as well. So all that had to be debrided. I think the key part here is to, in the revision scenario, is to actually to extract the implants with minimal bone loss, and then reconstruct your joint line, and then go to your components, and then use the least constraint that you can possibly do that. So in this case, we had to use augments to the distal femur to distalize the joint line, otherwise you get a patella baja, and then we used stems on both sides. So meticulous pre-op planning, understanding what the failure is before you actually go in, rule out infection, good surgical exposure. If needed, you can do an extensile approach, address the bone defects, and then go accordingly. Restore the joint line, which is the most important to be considered in a revision scenario, and select the optimal implants and try to use the least constraint as far as possible, and you optimize rehab. So that's a short video you can see. You can either get with the femur or tibia. I usually take out the poly first with a couple of osteotome taps, and here I've taken the tibia first. So you can use either a giggly saw, or you can use a saw as well to actually loosen the component between tibia and the cement mantle. So in this case, it wasn't much difficult. So the main thing is to not to have much bone loss. And then you go ahead with your tibial component preparation first, intramedullary, and resect just about 1 to 2 mm from the intact side. Never go from the deficient side, because you don't want to build up the tibial tray. And once that is done, then you go with alignment. Sometimes you may have to use an offset coupler to get an adequate coverage of the tibial plateau. And same time you adjust with the rotation. Then you go ahead with the femur. You size the femur either anteroposterior or mediolateral. In this case, we have used distal femoral augments to get the joint line down to prevent a patella baja. And you may have to use sometimes a posterolateral or a posteromedial augment, usually posterolateral, so that you can externally rotate the femur. So once you get through your femoral rotation, then you go ahead. You make sure that you have adequate bone stock. So once we have that, you put your trial components. And in this case, there was a medial gap of almost, I think 8 to 10 mm. And we used a 1 centimeter half wedge on the medial side, along with a tibial stem as well as a femoral stem. So that's the post-op X-ray. AP and lateral views. The second case, similar case, 62-year-old male with 2-year knee pain, left TK 5 years back, is a controlled diabetic. This patient had multiple surgeries. The index surgery was done somewhere elsewhere. And then about 2 debrimers were there. There was spacer inserted a couple of times. And this spacer was there for the past 3 months back. And patient was left with the spacer inside. You can see extensive lysis there in the tibia and femur, both views. As first you rule out infection, ESR CRP was negative, ultrasound was negative. So there was a dry knee. So we went ahead, explanted the implants as we usually do. There was hardly any metaphyseal support here. So in cases where you don't have metaphyseal support, one of the options is either to use a cone or a sleeve. In this case, we used a cone, which is independent of the implant. You cement it in, and then you go with the implants. So here, we've used them on both sides. And we used a hinge knee because of the gross instability that the patient had. One of the very important things to note is the patellar tracking, because sometimes when you overstuff, you can have a patellar mal-tracking. So always make sure that the patellar tracks well, otherwise patient will never be happy. The last case is a 72-year-old female, a bilateral total knee done 8 years back. Again, complaints of left knee pain, started 1 year back, but increased in the past 3 months. She had a deformity, obvious with the restricted ROM of the left knee. Again, infection to be ruled out first, ESR and CRP was normal. So you can see here, again, similar case, aseptic loosening, eccentric polywear, lot of metallosis, lot of calcifications along the sides. So you expect that the collaterals may or may not be very good. So you have, and in any revision scenario, make sure you have the entire armamentarium, sometimes with increasing constraints, including a hinge sometimes on table. So it's a long leg view, so scanogram that I do for all patients. You can see the left side varus thrust and the gate. So that's the examination under anesthesia, which is not very relevant in this case. Yeah, you can see that extensive, this was a oxinium knee that was used. In spite of that, you can see the extensive metallosis there on the medial side, which has been chipped off. So as you take out that blackish tissue, a lot of sparks, when you use electrocautery, you see a lot of sparks coming from the debris. So there you can see the eccentric medial wear of the plastic, and the metal component actually chipped off because of that direct altercation. So we explanted, and in this case again we have used a hinge with stems on both sides. You use an offset coupler on the tibial side to get adequate tibial coverage. So to summarize, in a revision knee, you always need to identify the cause of failure, otherwise you never go in. Exposure is paramount, multiple incisions. You take the most lateral incision, extensile, like a TTO or a quadriceps snip may be needed in tough cases. You explant with minimal bone loss, that's the dictum, that's the game half won. Establish the joint line and restore the joint line. Assess the degree of bone loss and act accordingly. You've got sleeves, augments, half augments to support you. And choose the least constraint that is always possible. Many times you can actually get away with a normal PS knee or a semi-constrained knee. Only with increased bone loss and increased soft tissue incompetency, you may need a hinge in certain cases. Thank you all. So I'd like to call the next speaker, Dr. Anil Oman, to present on his case on revision knee.